Good evening, friends and respected seniors. Greetings from Devbhoomi, Uttarakhand. Today, we are starting our new webinar series, State Arthrodesis, under the aegis of Uttarakhand Orthopaedic Association. We selected this name, State Arthrodesis, so that we can make strong bonding between our members and members of other state, other associations, so that we can know other members of other association, other states. Today we are having blessings with our office bearers of Indian Orthopaedic Association, President-elect Dr. Ram Chaddha sir. Welcome, sir. Secretary sir, Dr. NAVEEN THAKKAR sir. Welcome, sir. Vice President sir, Dr. Anup Agrawal sir. And President-elect Uttarakhand Orthopaedic Association, Dr. Puneet Gupta sir. Welcome, sir. Dr. Atul Srivastava sir, our president, he engaged somewhere in some urgent work, so he is not able to join this program, but he sent me his best wishes for our association. Thank you, sir. We are having panelists from our state, Dr.Vimal Nautiyal sir. He is joining soonly. He is our past president. Dr. I M Singhal sir. He is our immediate past president. Dr. Himanshu kochar. He is our immediate past secretary. Dr. Ganesh Singh, associate professor. Dr. Pradeep Pandey, senior arthroscopic and trauma surgeon. Dr. Tarun Solanki. I'm requesting to Dr. NAVEEN THAKKAR sir to say a few words for our association and proceed further. Thank you.
Yes. Good evening to everybody, and congratulations to Uttarakhand Orthopaedic Association for arranging such a beautiful webinar series. And this is a kickstart with the presence of all IO officials. Uttarakhand Orthopaedic Association is a very vibrant and active orthopedic association with great academic activities, and they have done a series of webinars previously also. Gujarat Orthopaedic Association and Uttarakhand Orthopaedic Association has done a combined webinars of various case discussions and everything. So I must congratulate Uttarakhand Orthopaedic Association and office bearers. They have worked very hard for such a beautiful academic program. And if you allow, because I have heard to catch the flight, if you allow, I can start the presentation. And then whenever you take the presentation of the next IO officials, you get a message and the presentation, or you want the messages first and then I have to present, whatever way you select.
Yeah.
Dr. Ramchandran sir, can I start the presentation so that I can finish and I can catch up the...
Please go ahead, Naveen ji. Please go ahead.
Okay. Thank you, sir. Thank you, sir. So I'm sharing the screen, and the subject chosen today is... Can you see the screen?
Yes, sir, it's visible.
It's coming, eh? It's
Yes,
coming very well. Okay.
Yes.
So it is just learning together. It is a together learning. So I may ask few questions to faculty so that it becomes a little bit interactive and we can start with some energy. So it is completely a learning together. So I'm starting with one case. Male, 52 years, operated in 2016, and the Enders nails had been done by the surgeon, and it is going for the non-union and breakage of the implant. Ganeshi, what will you do?
So this looks like a trophic non-union.
Yes.
No,
yes.
no callus is visible.
Right.
So
what will you do?
We have to, sir, we will revise it with plate or plus bone grafting.
You will go for the posterior plate or plating and compression plating and bone grafting.
And bone, yes.
Okay. The surgeon has done the same thing. He has done the removal of nails, broken nails, locking plate, bone graft. He has used the locking plate and the bone graft, and it went uneventful. Only complaint of the patient was feeling heaviness and tingling and numbness off and on. That was the only complaint, and patient came to same surgeon for removal of implant. Right? Now the story starts. He tried to remove the plate, but could not due to cold welding. Right? So again, it went to the another orthopedic surgeon. He also tried to remove the implant, but he could not remove the implant. What will you do? Suppose this patient has come to you, Ganeshji. What would be your option? Probably some of the screws are hitting here, but removal of implant was not possible by second surgeon even. Puneetji, do you want to say something?
Sir, it is very difficult to remove in such situation. So
Right.
sometimes we require Midas kind of thing to remove this thing.
So you will plan to remove the screw heads, break the screw heads.
Yes, sir.
Then how will you remove these screws?
With hollow mill I can try, but sometimes it becomes risky because this hole may become the
Yes, because
stress
of
riser
hollow,
site.
yes. Ganeshji, hollow mill here, hollow mill here, hollow mill
Yes,
here,
sir.
3 hollow mills here. I think he
So
could
we
remove
can-
what was the knot. He could remove this cortical screw, but then again he applied. The knot is such. But the hollow mill here, hollow mill here, hollow mill here, hollow mill here. Will
Yes.
it is not a
No,
practical
it is not
solution.
advisable. Yes, it is not advisable.
So the first lesson which we learned from this case is that do not take the case of removal of implant without preparation, or have a plan, something plan in your mind. It was very difficult to remove. And another message is, in such a good bone, it is not required always to use the locking plate. When you are doing a compression mode in a non-union, you can use a simple DCP, LCDCP without locking heads. Because the problem is with the locking heads. It's not an osteoporotic bone here. So now let us see how the story goes. The surgeon explained to the patient that the implant is not removable and the further try of removal may damage. And patient was shifted to room. What will you do if you are in that place? Puneet? You tried a lot in the OT, but you could not remove. Then what will be the most difficult part is to explain the patient, because many times we take these patients when we have no patients. And we ask them that I will remove the implant.
The only option is to remove from the other side, sir.
Other side.
But it is other side of the protruded part of the screw, but it is also very difficult. It's not so easy.
It is very also difficult. And if you notice, the surgeon has used the anterolateral route to remove it. If I go back, you see, this is the anterolateral incision he has used, right?
Yes.
So, as a second surgeon, he tried to do that and patient was shifted to the room. But now, patient has come to you. What will you do? So now the story, let me finish the story. The story starts now. Real story starts now. What next? Next is, this is the thing. Patient complained of pain and deformity after 3 hours of shifting to the room. So now, during the removal of implant, we have added a new problem. It's a peri-implant fracture here. Right, sir?
Yes, sir.
Now, it has come to you as a third surgeon. Now the real problem. Now the added problem. Who wants to take? Senior Puneet ji, sir? Anybody else from the faculty? Ganesh ji, are you there? I cannot see, I can see only Puneet. And he is also busy on the... Yes, Gupta sir.
Sir, yeah, because this implant is not removable. It has been done from the anterolateral aspect. I will treat it as a fresh fracture, new fracture, and I will approach from the posterior surface and will do the plating on that side. along with the bone grafting.
Yes. That is your
I'm not
option.
bothered about
Can-
the previous plate, but I'll like to treat the
have you approached the
fracture.
posterior aspect with such a high level of fracture?
Still, sir, but the only option is we have to explore the radial nerve first, and then we have to operate it. We'll have
So,
to
but
take care of the posterior.
posteriorly, you have an experience of going such a higher level posteriorly.
Sir, most of the shaft humerus plating I do from the posterior approach.
But this high level also.
Sir, it's risky, but then still we have to. I think that the one of the option for that is
you will go posteriorly. You will isolate the radial now and then try to
Yes.
do the plating on the posterior aspect, right, sir?
yes, sir.
Any other option? Any value addition from other faculty? Now it is. Imagine that it is your patient.
Sir, if
Yeah.
we are planning for the replating, the only option is the anterior plate, sir.
Yes. Who has
Anterior
spoken?
plate. Yeah, Puneet
Okay.
Agrawal.
Puneet, yes. Puneet ji.
Anterior plating, the proximal part is just below the neck or some below the bicipital groove,
True.
and the
Right.
distal part in between these two screws of the plate, I think.
Right.
That will be the only remaining option. Then in this situation, we can try to remove one proximal to screw or one screw so that we can put graft there.
Okay. You will try to remove this screw, proximal one here.
Proximal one, yes.
Yes, proximal one. This one proximal, right? Any difficulty you anticipate?
Any difficulty? The union will be very.
Yes, any difficulty during the surgery you anticipate? You said that you are going anterior plate, so you are going to open up the anteriorly. So whatever the anterior anterolateral incision or anterolateral incision is there, that you are going to take same incision, no?
So there
Yes,
will
yes,
be
yes.
lot of
This is the anterolateral.
Fibrosis will be there. Yes, fibrosis will be there.
Right. Any other solution than opening up the fully? Any other option? Okay, to save the time, let us go further. We did a reduction with the help of the flexible nail, and we tried to do MIPU anterior pleating. You can see here the flexible nail to get it reduced and keep it reduced, and a small incision here, and a small incision here, and the long plate. You can see from here to here, long plate has been used. 2 or 3 screws on the either side. This is the immediate post-op. This is the follow-up anterior breech plate with the flexible nail to help the guide the reduction and keep it reduced, and as a additional augmentation. And this is the follow-up united anterior breech plate. And you can see that only minimally invasive surgery, and it can be done with the minimal invasive surgery.
Sir, my question is, since there was a lot of fibrosis at your side, were you able to pass the plate through the MIPU technique?
Anteriorly, there was no fibrosis. It was anterolateral only. It was pure anterior plate, purely anterior, total on the anterior surface plate. So once you make a tunnel, it becomes tunnel very well with the plate itself. And this is the function. Yes, you can ask the question. So the theme of this time CME, which is going to be conducted by Gujarat Orthopaedic Association. So we invite you at the Lucknow. The theme is a case or a technique or an idea or an innovation which has changed my practice, may change your practice. So this is the paper which I'm talking, minimally invasive plate osteosynthesis of humeral shaft fracture. Is it possible? A cadaveric study and preliminary report. This man got the idea whether it is possible. So he tried on the cadaver and he looked for the cadaver and they tried it. So if you have something value addition along with this technique, and that may help my colleague, and this is an optional way to tackle the humerus fracture. There are many ways to tackle the humerus, starting from the conservative, but this is one of the way. What technique to choose? Many times difficult extended indications like these of the humerus. And we are discussing a lot of about open reduction, internal fixation, antegrade interlock intramedullary nailing, antegrade retrograde enders or flexible nails. But what is the problem? Why we are searching? Why whatever we have learned, we are again unlearning and trying to learn something new, relearn something. So it is a learning, unlearning, and relearning is going on continuously. The commonest problem described in the literature is the radial nerve injury with this, and rate of radial nerve injury, non-union, soft tissue, time of surgery, vascularity of the mid-shaft. These are the topic of discussion with this meta-analysis. This is the Bayesian network meta-analysis of 3 different surgical techniques for the humerus. It is under scanner. And this fellow has also checked danger zone of locking screw placement in minimally invasive plate osteosynthesis of humerus shaft. Because you are going minimally invasive. So you have to take care that screws should not go exactly posteriorly where the radial nerve is, because you are going from anterior to posterior in the screw direction. This is the incision proximally, this is the incision distally, and this is the plane of the cleavage, your dissection. Here is another one case where we have done a plating and it has given a good result. But again with this technique, what we found that it is also not free with the without problem. It is the problem. One is to keep it reduced. That was the problem. So the possible solution described in the literature is the external fixator, or you can use the locking sleeves and control the plate. But you require one more assistant to hold the reduction continuously. So this is one of the method. So we thought that we can add a value addition, particularly this case, this type of case. 52 polytrauma, expected problem, how to maintain the reduction. It is an extended indication with combination and instability. So it requires augmentation also if you are doing minimally invasive. So we have combined 2 minimally invasive techniques. That is a flexible nail from the lateral condyle of the humerus, where it gets very good entry and good support. Point of fixation at the lateral condyle. The bone is very good here, and you can get a good entry there. And you can pass the flexible nail from here. You can see here, these are the 2 incisions for plate, and this is the incision for passing the flexible nail. So you are not disturbing the rotator cuff or the shoulder. And it has given a beautiful result. And augmentation and further, patient is happy. So the scientific paper or a technique which may change your practice, and it may change the practice of others also. So we invite you again at the Lucknow for CME, where you can submit your idea or your technique, which may be helpful to our colleague. Another case, extended indication, fracture dislocation. Again, the same technique of MIPO, and it is giving a very good result. Again, another case of shaft femur and the flexible nail to reduce and the plate. Again, a good result with the happy patient. Good function, because you are not disturbing the soft tissue at all of the rotator cuff, as we are doing with the antegrade nailing or a retrograde nailing. So this is a possible value addition, and that has helped in my patients and may help to your patients also. Another case, extended indication. At least you must have a space for 2 screws here. Even if you have space for 2 screws, this technique is working very well. Flexible nail and the plate, anterior bridge plate, and you can see the good function. But the second problem, after doing a lot of series of this anterior bridge plate, removal was difficult. In small subset of patients where it is required to removal, the problem, what was the problem of removal? Anybody has thought of the problem here?
Yes, sir. Yes, sir. There is, because the holes in between the plate, the soft tissue gets involved. So
Yes,
we have already conducted a thesis on this topic and now we are facing all the patients, they are coming for the removal of the plate.
Yes. So here is the idea I am giving, the value addition. Here I am giving what we have innovated. This is the typical problem of soft tissue. The minimal invasive plate osteosynthesis becomes maximum removal. So it becomes, you cannot go blunt and blind. You have to see and have a sharp and open up to remove these all additions. So what innovation we have done and mechanical study is going on, we have to go back to the basics. We have to understand the problem and we have to decide how to tackle this problem and what can be the possible solution. So what we have designed is a special MIPO humerus plate where it is a smooth in between. There are no holes in between. And there is an oblong hole here and an oblong hole below. So there is no additions in between. And advantage of this plate in a good bone stock, you don't require locking. And it is a cost effective. So you can angle your screws so that you can increase the span of the plate or the fixation without increasing the length of the plate. But you have to be a good length plate. So it is under trial for this mechanical testing, whether it disturbs anything. So again, coming to the paper or a technique or a literature or the evidence, there is a literature that effect of the different surgical techniques on the mid or distal humeral shaft vascularity on an open reduction internal fixation versus minimally invasive plate osteosynthesis. Here you can see they have studied and they have found that minimally invasive plate osteosynthesis preserves the vascularity of both the fragments very well. And again, in the detail, this meta-analysis suggests that the current evidence indicate that MIPO is the optimum choice in the treatment of humeral shaft fractures, and that the open reduction and plate osteosynthesis is superior to intramedullary nail. There are small differences and every method is a small problem. But what they have come to the conclusion with the meta-analysis that this anterior breech plate is emerging technology or technique as far as the humeral shaft fracture when you decide to operate. So surgeon has to balance because every case has a different stress and strain curve, different gray area of instability. So we have to balance the stability at the same time flexibility. So must reduce the risk of the plate failure with the rigid fixation. We know that in humerus, conservatively treated get united, but somebody else fixed with the rigid gets non-union. And the optimum interfragmentary movement. So we have to learn from the nature. You can see bamboos. They are stable, but still they are flexible. So we need a stability at the same time flexibility in our system. Again, the same paper which I am quoting here, which has changed my practice, may change your practice. So this is the CME topic, innovation technique paper which changed my practice, may change your practice in Lucknow. So with folded ends, we invite you at Lucknow for IOCON 2023 and the CME. Please come and share your innovation, share your work there, research one. And particularly this appeal is the members of the Uttarakhand Orthopaedic Association, those who are not the members of Indian Orthopaedic Association. And there is a special request to office bearers. Please, please, please reduce the gap of the members in your state. Every state has a gap. They have a good membership as far as the state is concerned, but they have reduced number of Indian Orthopaedic Association members. So as my duty of Honorary Secretary of Indian Orthopaedic Association, I just appeal you and all the viewers and young orthopedic surgeons that please become the member. Because why I'm saying this, because the young orthopedic surgeons, this year, we have given 100 UA mentorship. 100 UA mentorship to young orthopedic surgeons. And this year also, we have earmarked the 50 lakh rupees for young orthopedic surgeons fellowships. But for that, it is mandatory to become a life member of Indian Orthopaedic Association. And for benchmark in the history of Indian Orthopaedic Association, now our website is very active and it is interactive and it is very easy to become a member. Just click the join IOA and you will be able to join the IOA with the complete list of the guide and everything is available there. There is no need to make a check. There is no need to check a draft. No paper. It is total paperless. You just submit your papers and automatically you will become the member. So this is a small request, and particularly young orthopedic surgeons this time, foreign affairs and the foreign fellowships, because of the very good communication between the IO office and the members, young orthopedic surgeons. This time we have a benchmark and record-breaking applications, 134 applications for foreign fellowship. And the foreign fellowship committee has worked very hard to scrutinize this all applications and put the marks. And we have put all the marks for transparency on our website, so that the young orthopedic surgeon can see their marks, where they are lacking, so they can improve upon next time, and they can get exactly the position which they want next time. And it gets gradually improvised. So it is now easy to become a member and join us. And now we have already started Aadhaar verification on our website as far as the transparency is concerned. So please log in, update your Aadhaar. It is very easy, 1 minute job. Now we are going to release its PDF file and help file, how to do it. But it's very easy. You can go on the website and you can do it. So again, I'm thankful to all Uttarakhand Orthopaedic Association office bearers and all the viewers and all the members and office bearers for allowing me to share with you this subject. Thank you very much. If you have anybody has any question, I can answer the question.
Sir, can I ask a question?
Yes.
Sir, is it recommended that in the distal screws, do you always explore the radial nerve?
No, we are
Or
not
it should be
exploring.
sometimes
we are not
few of the
exploring, but
literatures,
it is recommended that do not use the spikes.
Yeah.
Do not use the spike. Use only Langenbeck with the gentle retraction, and you can feel it. 2 holes lower down, you can feel it. And with the drill sleeve, you can put 2 screws. You do not require to see the radial now, because we are anterior. It is particularly required if you are doing a MIPO of the Philos plate, where it comes exactly on the anterolateral side. So there it is required, but here it is not required.
And there is also in controversy that 2 screws each side or 3 screws should be used.
No. It depends on the stability. How much stability you are required. More the combination is the advantage, because the more the combination, your stress and strain is distributed in a wider area. So more the combination, you have to have less screws. Less the combination, the stress is concentrated at particular level, fracture level only. So there you need a stability. And now with this technique, we are doing a flexible nail with the plate. So that has given a very good advantage of augmentation. Without disturbing the endosteal blood supply, we are putting a intramedullary implant. Very flexible nail, which goes from the lateral condyle.
And should we always use cortical screws, or in between we can use locking screws also?
You can use, it depends on the locking. Ultimately, innovation of the locking plate is for the poor quality bone, nothing else. Locking heads are required for the osteoporotic bone. So that depends on the patient criteria. But always you can use simple screws. Why to use
My observation is that if we are using 2 screws only on both sides, by the way, if one of the screw becomes loose, it makes the implant unstable. So in those cases, we can use the locking screw also so as to support that.
But the locking screw also get loose, because locking screw gives the false security, because it locks in the plate. That also gets
it's not locked with the bone.
It's not locked in the bone. So
but
that
if
is
we
not
use
but if you feel that it is unstable, the only test which is important, then you fix up the 2 screws on either side, and you try to rotate external and internal rotation, and see on the C-arm live, not a static, it is a dynamic. And if you see that there is a rotational movement between the two fragments, you can add another screw. That is the only way, because it is case to case. It cannot be a cookbook. So it is a case to case. So you have to check the stability. The particular problem is the rotational stability. Alignment you have done. You have done the axial stability, but the rotational stability is the most important part. There you have to add this third screw on both the sides. Or if you feel while drilling and putting that screw that you have felt not a good sense of stability, then you add a third screw. Is it right, sir?
Yes, sir.
Yes, sir. Thank you.
Thank you.
Thank you.
Thank you, sir. So can I take a leave?
Yeah, sure, sir. Thank you, sir. Thanks for
Thank you.
your
Thank you all.
presence, sir.
Thank you. I'm stopping the sharing, and I again thank you, and I'm leaving the meeting, sir, with your kind permission. Dr. Ram, I'm leaving.
Yeah.
Thank you. Thank you.
Thank you, sir. Thanks a lot, sir.
Thank you. Thank you.
So now I'm requesting to Dr. Ram Chaddha, sir, to present his talk on decision making in acute on chronic low back pain.
Good evening, everybody. On behalf of the Indian Orthopaedic Association, I welcome you all and congratulate you on an excellent theme where you are adhering and arthrodesing the various states together. And you've chosen a large number of good speakers. Is my screen visible?
Yes, sir.
Okay.
No. Screen is not visible, sir.
Screen is not visible. Give me a moment. Is it visible now?
Yes, sir.
Okay, great. So today I'm sharing the little that I know on decision making in acute and chronic low back pain. I have been handling low back pain for almost 35 years now. And it's my privilege to share the mistakes I've made and what I've learned over these years. We all believe that chronic low back pain is related to degenerative disc disease, but we don't know whether it's purely an aging process or whether it's an independent pathology. Why do we say so? Well, this is two grayish-black discs and two grayish-white discs, one of which is herniated. This is multiple grayish-white discs and two grayish-black discs, which Schmoll's nodes. This is various stages of degeneration from a white proteoglycan-filled annulus fibrosis with a good nucleus to a completely degenerated lumbosacral disc. And this, unfortunately, is a young man, comes under a category of juvenile degenerative disc disease, where he actually had this in his late teens. And I treated him for almost 5 to 6 years before he came to me, finally, with a problem. He was 26 years old when I saw him. He was doing weight training as a passion, as most youngsters do today. He was a marathon runner. He had back pain for 3 years, which was worsening. I was treating him non-surgically. He had left leg pain since the previous marathon on the left side. And he had quit smoking at the age of 20, which means he started in his early teens and quit it at the age of 20. Now he came at 26 with some claudication, paresthesia, neurological weakness in the left L5-S1 dermatomes. And unfortunately, a red flag of urgency in his sphincter. This is what got our tentacles coming up. We did an X-ray of the LS spine, AP and lateral views. What to do next? Well, I thought, let's do a flexion extension X-ray. No gross movement, but yes, there used to be some calcification of the annulus at the L4-5 level. Nothing else visible in this patient. Some early calcification with retrolysis at 3-4. We went ahead, studied it, studied all the MRIs, did the axial cuts. Interestingly, found left L5-S1 total lateral recess stenosis with a large disc, acute on chronic, a left posterocentral and foraminal disc at 4-5, and more of a posterocentral disc at 3-4 with lateral recess stenosis left more than right. But he was just 26 years old. What do we do now? We evaluated the rest of his spine, which was pristine, clean, good. Do we do a CT scan? Do we do EMG nerve conduction studies? Do we do a discography? Do we give him root blocks? Do we also rule out other things like doing an HLA-B27, RA factor, anti-CCP, ANA? Do we do his other parameters to look for low back pain causes like vitamin D3 deficiency, B12, folic acid, HLA-B27, RA factor, any or all of the above? Well, there was a lot of consensus, more of controversy. But this young man now had a bladder problem. We had to choose between what we were doing for the past 3 to 5 years, non-surgical versus surgical. Where did we go next? We now came to the 3 most important parts of our discussion and the way forward. Counseling, counseling, and counseling. In such patients, it's always a shared informed decision, a decision between the person who's suffering, we as the caregivers, and of course, the patient's family, which in our country is an integral part of decision making. What did we now do? Well, we wanted to know that if we are going to intervene and do something invasive in this man, why are we going to do it? What's the purpose of the intervention? If you're going to do it and we know why we are doing it, then we'll think of how to do it. And finally, we'll decide what to do. This is actually contrary to the way that most things are happening in our country and worldwide today. People say, "Main implant dalunga." Then they say, "Main usko minimally invasive dalunga." And very few of them know ke kyun dalunga. Unfortunately, thinking has to be turned the other way around. If a patient needs surgery, you should know the purpose, why. Then the process, how. And finally, which product you're going to use or what, rather than the other way around. So yes, the why begins with the fact that this gentleman needs decompression. Where all does he need decompression? Probably at all the 3 levels. Would we do a fenestration? Would we do a laminotomy? Or would we do an interlaminar discectomy? Or would we look at the conventional whole hog complete laminectomy? Your guess is as good as mine. If we decompressed, would we think of fusion or give him a non-fusion option because he's just 26 years old? Well, we had a lot of non-fusion options available then. We had the flexible rods, we had flexible cables, we had springed rods, we had knurled rods, we had everything available. We also had the interspinous devices, and we had the disc replacement, which came in and disappeared in the lumbar spine, but was available. With all these options, where did we go next? Well, we thought he has significant back pain as well. Fusion to karna padega. Somewhere we'll have to fuse it. But where? Would we fuse all his 3 lumbar levels lower down and give him a stiff spine from the age of 26 onwards? I was not willing to accept that. Would we then use a hybrid option where probably we'd fuse one, decompress the other, and maybe give a flexible mobile segment above? Well, we played with all these options and did a combination of all 3. At L5S1, I did a T-lift from the left side. At L45, I did a decompression with a posterolateral, complete decompression, but a flexible rod. And at L34, it was just a micro decompression. So I combined all the 3 things from below upwards, fusing, flexible, and complete mobility. This is what it looked like immediate post-op. The skin staple suggests that it was immediate post-op. 7 years down the line, which is also 5 years back, this is what he looked like. He is still running the marathon, is now getting close to 40 years of age, and is doing well. What did we learn? We always follow the principle of treating the man and not the scan. I follow an acronym called MIRACLE. Minimal invasiveness, risks, and cost having a lasting effect. Which brings me to where we have our discussion today. 45-year-old, middle gentleman, middle-aged, chronic low back pain. Suddenly, 4 days back, developed severe right more than left leg pain. mainly in the L5 dermatome. And this is what it looked like. A large disc extruded at L4-5 on the right side. If we were to take it out, this is what it would look like. Neurologically, his right L5 was a shade weaker, EHL, extensor hallucis longus. What do we do now? Well, a surgeon's hands are itching and he wants to do something immediately. But do we conserve or do we operate? What does evidence, expertise, and experience say? Well, it says we should not operate these patients immediately. With a mild early deficit, what do we see? At 25 months, 75 to 100% of them resolve, more than 50%, almost 50%. Almost 40% have 50 to 75% resorption, and only 12% have less than 50% resorption. So most patients at the end of 25 months have MRIs looking that well, but believe me, the man feels much better than the scan. Between 6 weeks to 3 months, a lot of them turn around, and you can, if you handhold them, giving them reassurance, pull them through, taking care that they don't step into the red flags of loss of bladder and bowel or cauda equina, or further weakness of the EHL or the EDL or the T-band. Having said that, it is a very, very challenging course to follow non-surgically, but give the patient the best option and take an informed, shared consent. Which discs regress? The more degenerated the disc, the higher the chances of regression. The greater the size of the herniated fragment, the greater the chance of regression. Young discs, which are contained in a narrow lateral recess, do not really regress. In fact, it's those large, centrally placed discs which shrink and disappear. There's no real correlation between the site of herniation and regression. Do epidural steroids help? Well, there's no difference between using epidural steroid and not using epidural steroid as far as regression is concerned, but the radicular pain can be masked, and it can be used as a mid-part at a perineural injection. Whichever way you go about it, transforaminal or otherwise, can reduce the radiculitis and make radiculopathy appear better in a quicker period of time. Is there any natural history that neurological deficit will reduce with disc herniation? Well, if there's a mild deficit, it's an overall good prognosis. If recovery is seen in the first 3 weeks, it's always good. But if it doesn't recover beyond 6 weeks, you have to have your antennae open and probably think of surgery. Sensory fibers are most susceptible to compression and the last to recover. And resolution is not affected by surgery. Rarely, this low back pain is associated with mild instability. Well, in those cases, you may need fusion. What are the types of fusion? Posterolateral fusion, PLF, posterolumbar interbody fusion, PLIF, transforaminal lumbar interbody fusion, TLIF, oblique lumbar interbody fusion, or OLIF. This is from where you put the graft, put the spacer. But why do you do that? You do it if you have an unstable, painful, mobile segment. You also do it if you have deformities like listhesis, scoliosis, or a flat back. And sometimes jacking up the disc space also causes an indirect lateral recess decompression. When you do a PLF or a posterolateral fusion, well, it works well for multisegmental, and it can be done for low-grade instabilities. Where you do PLIF, interbody, where you're putting graft from both sides or spacers from both sides. In this case, I would do it for high-grade listhesis, or I would do it for post-operative discitis. I would not do a PLIF from both sides for a low-grade listhesis or an easily correctable grade 1, 2, or even at times a 3 listhesis. Of course, if the patient has unilateral symptoms, I would put it from one side or transforaminal, where I would put in a spacer through the TLIF approach, get down one facet, knock it off on the side that it is affected, and put in my spacer and put in my 4 screws. That's my gold standard. Yes, today we have the new kit on the block, which is the OLIF, which is done as an anterior psoas approach. Earlier it was trans-psoas. It's now done more anterior to the psoas. And you put in large spacers from side to side, which can go and support and do a percutaneous procedure of rods and screws from the rear. So it's a back and front approach where you're doing an OLE for an X-slip from one side and a posterior percute screws from behind. Works very well in revision cases, especially adjacent segment disease. So what are the lessons that we've heard in treating acute and chronic low back pain? One, if there are more symptoms than signs, which means neurology is hardly there, let the patient buy the surgery, don't sell it to him. If there are more signs than symptoms, weakness, sensory, motor, early bladder bowel, something of that sort, counsel about the need for surgery. In early osteoporotics, where there's not much of neurology, aggressive medical therapy, and I use everything from bisphosphonates to monoclonal antibody like denosumab to teriparatide in whichever way I can, because I believe osteoporotics also need good health. Complex lumbar canal stenosis, where there is scoliosis, listhesis, redo, less is always more. And in those severe osteoporotics where you have to operate, where there's no other go because there is neurology coming in and you can't build them up for 3 to 6 months with anti-osteoporotics, there use bone cement, use BMP, use screws, wires, use artificial intelligence, RoboNav, whatever you have minimally invasive, do it in a tertiary center, have a good ICU backup. Don't touch these patients who are elderly and moribund in small nursing home setups. Where are you in the future? Well, fusion will at some stage probably get replaced by non-fusion. Open is already getting replaced by minimally invasive. Instrumented and non-instrumented, less is more. And soon there will be less of implants. Gene therapy versus biologics versus metal. My guess is as good as yours. We don't have an answer yet. Ultimately, in our country, we would need cost-effective and safe options. Coming to my final slide. We hear a lot of people talking of evidence, a lot of people talking of experience. Very few talk of expertise, which is where you have both. And why is that so? Because people are in a hurry. They always practice the Dunning-Kruger effect. The more you know, the less confident you're likely to be, because experts know just how much they don't know. They tend to underestimate their ability. But it's easy to be overconfident when you have only a simple idea of how things are. Try not to mistake the cautiousness of experts as a lack of understanding, not to give much credence to lay people who appear confident but have only superficial knowledge. Bertrand Russell, I quote, "The whole problem with the world is that fools and fanatics are so certain of themselves, yet wiser people are so full of doubts." Practice the anagram of listen and silent, LISTEN, SILENT, same letters. Because when you listen, you probably gain a lot. When you speak, you only share what you already know. Behind every successful person, a lot of unsuccessful years. I've shared my mistakes, my errors, what I've learned over the last 35 years. And I would like to say, good results come from experience. Experience only and only comes from bad results. Thank you all for a very, very patient hearing. I'll be happy to take whatever questions you may have. Thank you, Uttarakhand Orthopaedic Association, for having invited me. God bless you.
Thank you, sir. Thank you. Yeah. Dr. Puneet, sir. Are you there? Hello?
Yeah. Hello.
Any questions?
Yeah.
Hello. Yes, sir. Any questions, sir?
Sir, a patient, young patient, you said that he's started developing numbness. Do we still have to wait for the surgery, or you said that we have to wait for the red flag signs? How do we convince those patients to continue conservative treatment?
Sir, we don't convince the patient for anything. We let the patient convince us that they need surgery rather than we convince them that they need surgery. So for me, if a patient buys the operation, I take it. I never sell it to him. So if you have a patient who's a high demand patient for whom an EHL grade 4 and paresthesia is significant, yes, I'll offer him surgery. But if I have a patient who just has these two, I'm not going to scare him and tell him tomorrow you will need your lose your bladder and bowel. No, sir, I don't scare them. So as I said, it's an informed, shared decision.
Okay, sir.
Sir,
Thank you, sir. Thank you.
In the same scenario, what is your advising? Should we go for only decompression or fusion despite there is stable spine?
So if there's a stable spine, I do not insist on a fusion. I try to maintain the flexibility. I like to do as less as I can because I believe less is more, especially in the young spine.
And the same scenario in old person?
In all patients, less is more as far as unstable spine is concerned. So even in the elderly person, an early degenerative listhesis, which on flexion extension hardly moves, I may just do a decompression and come out. I will not necessarily put screws rods. Where on flexion and extension, the degenerative listhesis stays the same. No problem.
So many patients presented late, sir, like they have large discs since 3 year, 4 year, but they recover. And after 4 year, they develop the symptoms. And sometimes they have red flag also. So is there any extra advantage, or what is your suggestion? Ki we have to operate in these patients, or we should keep watching this patient?
Sir, if there is a red flag which is of acute onset, you have to operate. There is no discussion. And you have to tell them very clearly why you are suggesting surgery. Red flag is cauda equina, recent loss of worsening of neurology under your care. You know, these are red flags. Sensory worsening, motor worsening, all these. There
Practically, will these signs recover after is such a long?
No, sir, I never promise recovery to any patients. Never. I never promise recovery to any patient. I'm very, very clear to all my patients that I can at the most halt the progression. At the most halt the progression. Recovery, if any, is somebody else. I am an instrument of a much larger force. I just execute. The recovery is in somebody else's hands.
Yeah.
Can I ask a question, sir?
Yes, Anupji.
Sir, I'm not confused about osteoporotic fracture in a middle-aged male or female, one level fracture, painful. Now, there are a lot of instrumentation. If I have the facility of instrumentation, things like augmentation by cement or balloon kyphoplasty, what should be the choice given to the patient?
Sir, I didn't ask the question. The question was middle-aged or elderly osteoporotic, sir?
Middle-aged.
So what is middle-aged and osteoporotic? That means it's a primary osteoporotic? We are not
primary osteoporotic. When I say middle-aged, it is somewhere around 50, 55, elderly 60, that rate.
Okay, so you are talking of either a postmenopausal osteoporosis in a lady or a senile osteoporosis in a man.
Man, yeah.
And the fracture is an osteoporotic fracture. You may or may not have a DEXA at that time. That's fine. Patient is osteoporotic. In this situation, again, my primary line of treatment if the patient is neurologically intact is non-surgical. I repeat, my primary line of treatment in this patient, if the patient is neurologically intact, osteoporotic fracture is non-surgical. And I first rule out everything from doing a DEXA if my patient is mobile to doing a serum protein electrophoresis and ruling out multiple myeloma, because this is the commonest that we should not miss. I do a D3, B12, HbA1c, uric acid, calcium, serum PTH, and a serum creatinine. Having done that, I do a DEXA. With these in my hand, I start medical management of the treatment of whatever it may be. I protect him with or her with a brace. I allow them ambulation with an anterior hyperextension brace. I do not use a Taylor's brace. I repeat, I wear an anterior hyperextension brace. I do not use a Taylor's brace. I start them with ambulation. These patients, a lot of them will settle with a mild acceptable kyphosis. A few of them will not settle, will have transition pain. That means every time they lie down to get up and get up to lie down, they have severe pain. These people at 3 to 6 weeks will need a sitting and a supine lateral view to see if they are developing a Kamal sign or a pseudoarthrosis. If they're developing a Kamal sign or a pseudoarthrosis, then start thinking of early non-union. That's where you have to then think of intervention, not for the first 6 weeks. First 6 weeks, give them best non-surgical care in neurologically intact. Neurological involvement in osteoporotic fractures is rare and few. There your thinking changes, then you start thinking like a traumatic fracture, no problem. But otherwise, non-neurological, give them time, give them 6 weeks, give them pain relief. A lot of them, 80 to 90% will settle. A few will develop that pseudoarthrosis or Kamal sign. Yes, there you have to then plan and execute. Long segment, with or without cement, kyphoplasty, posterior shortening, back, front, various options. But medical management, most important.
And ambulation from day one with brace.
I allow ambulation within limits of pain. And I encourage ambulation in the elderly. Keeping them in bed is asking for trouble in the elderly.
Yeah, that's where actually, that's where there is a confusion. Because you want with conservative, that's how it is being placed, that with conservative, you have to ambulate for a long time. And probably that is the selling point for the surgery, that you will start moving from the day one post-surgery. So there is a lot of confusion. This is probably where I am at least confused.
So this is where we were 8 to 10 years back when we started just cement augmentation or vertebroplasty. We burned our fingers. So I'm now coming to that you restrict it to those few who really need that cement augmentation. Don't sell cement augmentation to everybody. It's not as simple as it appears.
Thank you, sir.
Okay, thank you, sir. Thank you, Ram, sir. Now I will proceed to Dr. Anup, sir. His talk is on humerus, fracture proximal humerus plating, how to do it right. Dr. Anup, sir.
Thank you, Puneet. Should I share my screen?
Yes, sir. Yeah, it's visible, sir.
So once again, thank you both Dr. Puneet for giving me this opportunity to be in this webinar, which is probably one of the first webinar for this year. And I'll be speaking on a simple yet little complicated subject, that how to do it right. There are a lot of confusion around philosophy. Still few things are not clear. So why actually, what are the challenges? Why this topic is required? Because it's really difficult to have a secure fixation of the implant on the bone because of the osteoporosis, because there is less cortical and cancellous bone, especially in the head area. So the pull-out strength is very, very less in all these head area of proximal humerus fractures. So the main advantage with philos in osteoporotic patients or elderly patients with proximal humerus fracture is higher resistance against bending forces, less screw loosening. I won't say no, but yes, less, decreased secondary loss of function because of loss of fixation. So the key to success in putting a philos is, I'll cover up all these points: proper approach, minimum soft tissue damage, axillary nerve care, proper reduction, suture fixation of tuberosities, proper placement of plate and screws, how to put a calcar screw and when to pull a calcar screw, what are the necessities of medial augmentation, and early physical therapy. I'll pick up one by one. So there are basically three different approaches: deltopectoral, enteropectoral, enterolateral, and transdeltoid lateral. That is the MIS normally. So these are the three approaches. Out of that, we all know deltopectoral is the commonest approach, which most of the surgeons prefer. Few go for enterolateral, and minimal invasive is not being done by everybody because only the experienced surgeons can do. But every approach has its own advantage. Like deltopectoral, if you have a varus kind of fracture, if you have more medial comminution, and if the patient is bulky, it is easy to handle through a large deltopectoral approach, because you can extend the incision both proximally and laterally. With transdeltoid approach, if you have a valgus fracture, plus minus tuberosity fracture, and especially if GT is comminuted and grossly displaced, then with this approach, you can very well manage that GT. With minimal invasive deltoid split, as I said, you need more experience. And Many of surgeons are unfamiliar with it. They damage the deltoid. There's direct manipulation of axillary nerve which is involved. You need to feel it, assess it, and then difficult to assess the medial cortical comminution with this approach and assess the medial pillar stability, which is one of the key. And problems are there in converting to orthoplasty midstream if ever you need. So, as always, in every fracture management, we talk about minimum soft tissue handling and minimum soft tissue damage so that the blood supply to fracture fragment remains same. That we have to follow here. Whatever the approach may be, but your soft tissue handling has to be good. A word about axillary nerve. Now, this is very startling figures which had been quoted in this publication in 2001, where they talk about they had done an EMG of all those patients and they documented that a nerve injury could be present in 67%, and out of that 58% would be of axillary nerve. Now, when they talk about axillary nerve injury, not necessary that it's a complete injury. They're talking about many a times neuropraxia, which is impossible to assess without EMG, at least in injury when a patient has the injury. The only way to assess these are to do an EMG. In post-op or per-op, if your handling of axillary nerve is not good, then these injuries of axillary nerve, which were neuropraxia, may get converted or may get further a delayed recovery because of further injury. So you need to be really careful while you are handling the axillary nerve, whether you are using a deltopectoral approach or MIS transdeltoid approach, where also you should always put your finger inside and feel for the axillary nerve and then put your plate underneath. Now, if you look at these two fractures, one is I'm talking about proximal femur, another is proximal humerus. Mechanism of injury is different. The whole biomechanics of healing is different. The muscle pulls are different. But still, if you look at the fragment and the way it is needed to be reduced, the whole thing looks quite similar. You have 4 fragments: GT, greater tuberosity, greater trochanter, a head fragment, then a lesser tuberosity, and a shaft fragment. If you have understood the concept that how all these fragments are important to stabilize and how these things should be reduced, then probably you know about the proximal humerus also. So these are the 4 fragments, and most of the time, you have to reduce each and every fragment to this position. And before that, you should know how these fragments are normally being displaced. So if you look at the head fragment, it is mostly inferior or posteriorly where it is difficult. Greater tuberosity is abducted, that is gone posteriorly and superiorly, and lesser tuberosity medially. And if you know this concept, then probably you will be able to reduce them well. So what you should do, these are all 4 fragments. You have to reduce them, make them one, align them, and then fix. So always a proper reduction is necessary. When I say proper reduction, what does that mean? That is, maintain a proper neck shaft angle. We all know it is normally 130 to 150. You have to come in between whenever you are reducing. So your neck shaft angle, head shaft angle has to be proper once you have reduced. And there should be a medial continuity of the fragment. And this is very, very critical for success of your whole fixation and the functional result. And this has been proven by this study, which was published in 2009. There, the analysis showed that any delay in rehabilitation because of comorbidity and decreased head neck shaft angle induced by lack of medial support were the primary prognostic factors that led to poor outcome. So these two important, maintaining the head neck shaft angle and medial community, are very, very important prognostic factor to have a good result. Now, how to actually reduce the fragment? You could have a varus or the valgus position of the head. If you have a varus displacement of the head, then there could be many methods. You can put in K-wire into the head from the anteroposterior side, anterolateral side, and then pull it back. Or you can utilize the suture over the head and pull it back, or both the things. Or you can put some sort of retractor or anything, use it as a joystick through the fracture side and elevate it and reduce it, and simultaneously use the arm to abduct it. So there could be various methods, and sometimes even after these methods, sometimes you need to actually put in your finger through the an interval between rotators, and from there you can go to the upper border of subscapularis tendon and reduce the head to a proper position. If you have a valgus position of head, again, either you can use a K-wire, or most of the time it is some kind of elevator where you can push through the fracture and then reduce it to a normal position. Once you have reduced the head, the next thing which comes is picking up the tuberosity from the posterior and the medial side, suture them well, and bring them anteriorly and close them. How I do it, I always, the supraspinatus tendon, lesser tuberosity, greater tuberosity, I pull all of them and suture them together first. So you can see in this picture, all these fragments have pulled forward and they have been sutured back together. Now this makes whole of the proximal fragment as one reduced piece, and it becomes easier for you to align this with the shaft. You can see that without any further K-wire, how well it is being reduced. Now, only thing which you have to adjust is now the neck head shaft angle, which will be required. So once you have reduced this tuberosity, you have to reduce this whole proximal fragment and put the plate. Now for varus, never ever try to first put this screw onto the shaft and then try to reduce the whole fragment through the plate, because you will not be able to. So you'll have to pull back, correct it, then put the plate and then fix it like this. While if you have a valgus position, then probably plate can be used as a reduction tool. Like here you can visualize that first you put your distal screw, and thereby you can reduce the head fragment by tightening the screw, and it is well reduced like this. So plate can be used as a reduction tool only in valgus, but not in a varus dislocated varus position of the head or the proximal fragment. Once I position my plate, then what I do is always pass all those suture again through this and bring them anteriorly towards the plate, and then I fix them together, again bind them to make one whole scenario like this. This is an example how it is being given, that head fragment is very porous. By tightening the greater both the tuberosities and head fragment together, and then again by the plate, increases the strength of your fixation 3-4 times. So always do that, and that is how to do it. Now, how you should place your plate onto the shaft. The plate should be placed 5 millimeter lateral to the bicipital groove, and proximally you have to put in the K-wire to assess. Now, why I'm showing this, many a times I have seen people put the K-wire through the most proximal hole and try to assess. Whenever you are trying to assess the proximal position of plate through this wire, pass through the plate, you will always put your plate much more proximally and will cause an impaction. So always use the zig proper and then assess the placement of plate, and that is how you put the plate proximally. Once you have positioned the plate, always make sure that you are not only just seeing the AP view, but always check the lateral view to see the typical bulb position, and the plate is distally well aligned to the shaft. Only then start putting your distal screw first and then proximal fill. Now, another word of caution that what should be the position of a screw? What should be the depth? So the tip apex distance should be as minimum as possible. We have learned in proximal femur that it should be within 10 mm, but here you have to be as close as possible to the articular surface. Mind it, whenever you are putting your screws, always check in AP lateral oblique position, repeatedly check, because many a times your side screws, they are going towards the posterior. They are 30 to 35 mm, which is required. And if you go more than that, you'll not be able to assess if you're just assessing into AP lateral position. But actually, those screws will be out of the head. So always check the position of a screw in many directions, AP, oblique, lateral, and then go ahead further. Now, a lot of discussion comes about calcar screw, whether to be put or not put. As I told you before, that loss of medial support is the most common reason for secondary displacement with varus impaction. There are many studies. One such a study where they talk about how does a varus deformity of humerus head affects the elevation forces and shoulder function. And they concluded that any varus displacement of 20° already significantly elevates the forces of the rotator cuff for elevation movement. And dislocation and even penetration or cutout of the locking screw, especially in fracture with varus impaction, is reported frequently and can cause severe cartilage damage of the glenoid cavity. Another study published by Gardner et al., and they have shown that loss of medial support results in a 5-fold higher cutout rate of the locking screw. And in their analysis, a fixation is considered to provide adequate medial support if the medial cortex is intact and is anatomically reduced and not comminuted, or there is a stable head-on shaft impaction, or a superiorly directed oblique locking screw, which we call a calcar screw, is appropriately placed into the inferomedial quadrant of proximal humeral head. So there are three important things for medial support: that you don't have a comminution, or the medial cortex is anatomically reduced, or there is an impaction on the medial side. That means it is stable. Otherwise, you would need a locking screw. So any fracture where there is a medial continuity or medial stability, there is no requirement of putting a calcar screw. While if you have a medial discontinuity or there is a medial instability, then you would need to put a calcar screw. Depending on position, you can put in 1 or 2. If you're trying to put a calcar screw through this one, you have to be careful. Try to avoid through this hole, because this can cause damage to axillary nerve. A word about the role of osteobiologics in proximal humerus. If you have a significant metaphyseal comminution, which is more apparent after reduction, you should go for either a bone grafting by a cancellous bone or a fibula strut. Why I am talking about fibula strut? Because elderly osteoporotics have limited quantity and quality of iliac crest graft. So fibula strut is best. Or you can use bone graft substitute like cement. This one study has established that initial biomechanical properties of internal fixation measured with use of proximal humerus osteotomy model, and 3 methods of fixation were significantly improved by addition of calcium phosphate cement. So you can use the osteobiologics or graft to stabilize these fragments first if you find there is a lacuna. So these are some of the important lessons or the things which you should know. And if you take them into the consideration, probably you will be able to give a good result. When to start physiotherapy? I normally start exercise on 4th, 5th day when the pain has gone and significant swelling has gone. Start with a passive range of movement and pendular exercises. And thereafter, as the pain allows, as the quality of your fixation, depending upon the associated injuries and patient compliance, you start your rehabilitation process. So to sum up, I will quote this study where they have summed up the proximal humerus management beautifully. They concluded that a majority of minimally displaced fractures can be treated conservatively with early physical therapy. Yes, there is a role of conservative management. Treatment for displaced fracture should consider the patient's level of independence, the quality of bone, and surgical risk factors. Fixation with percutaneous techniques, intramedullary nails, locking plates, and orthoplasty all are acceptable treatment options. There is no clear evidence-based treatment of choice that this one is better and this one is bad. The surgeon need to consider their comfort level, their skill level with the various procedure vis-a-vis the requirement of patient and the fracture during the decision-making process. Thank you.
Thank you, sir. Thank you for the nice presentation. You elaborate everything from the basics to advanced and post-operative management also. There is one question from audience. Dr. Gaurav Sanjay is asking, what are the tips and tricks in 4-part fracture dislocation when there is a head split fragment? And how does he know, is there enough purchase in a head split fragment as it is to penetrate intra-articular in small head fragment?
See, it depends upon if the head is split in 2 parts, that which if you have a larger, more than 2/3 of the head is intact and there is a smaller fragment, then probably you can go with it. But if there is a head split fracture which is much more comminuted and elderly patient, then probably arthroplasty is the right treatment. As far as purchase is concerned, it is almost impossible to really assess. That is the reason of failure of philos in many of the patients. So now how we follow is, I talked about the TAD, that as close to the articular surface as should be possible. All your screws should be fanned out and try to fill up all the proximal screw. The problem, that is the problem with indigenous Indian plate. Many a times you feel that screws are not fanned out like this if you compare the other plate. So always look before you are using any Indian plate that your screws are fanned out all around the head. That's one, that how you, and that is the reason fixation of greater tuberosity, tightening of greater tuberosity along the head fixation with the plate is very, very critical, which increases the strength of overall your fixation.
Thank you, sir. Any other questions?
Sir, can I ask a question?
Anji sir.
Yes, sir. Himanshu, sir.
Yeah, I'm driving at the moment, but the thing is, sir, if you have, after opening the fracture, if you find that the rotator cuff is completely gone, so what is your take on that? Sometimes this happens in elderly patients that the rotator cuff is not there, and there is a 3 or a 2-part or a 3-part or a 4-part fracture of proximal humerus. So then how do you go about it?
Sir, if you're talking about the completed rotator cuff, then you have only thing which is left is the reverse shoulder, because the normal shoulder orthoplasty even not work in that. But if you're talking about the partial, then you can do a repair of the supraspinatus then and there and bind all of those together, and then you can go for the fixation.
So how do you compare between a hemi and like not for the for cuff patients, but how you compare a hemi arthroplasty vis-a-vis a reverse shoulder?
I didn't get
like
how I compare. Both are, sir.
For a normal orthopedic surgeon, what is the message to be traversed?
Sir, or if we compare hemi with the results with reverse are better, long-term result. Number one. Number two, in the absence of rotator cuffs, the performance of hemi is always bad. You cannot go for it. And again, for a normal orthopedic surgeon who does not have an experience of either hemi or a reverse arthroplasty, that is not a surgery which should be committed by a surgeon who is not experienced into this.
Okay. Thank you, sir. Thank you so much.
Thank you, Anup sir. And
Thank
now,
you.
I will request to Dr. Puneet sir. Puneet sir, are you there?
Yeah.
Yeah. His talk is on outcome of surgical treatment of hip fractures in elderly patients with multiple comorbidities. Over to Dr. Puneet sir.
Okay. Good evening, everyone. I'm sharing my slides presentation. So my slides are visible now?
No, sir.
Is it visible now?
Not
No,
yet,
sir.
sir.
Not yet, sir.
Sir, bottom of the screen पे share screen पे जाइए sir. Bottom of the screen पे. Center में जो green knob है नीचे से.
Arrow बना हुआ है सर उस पर.
Yeah.
उस पे डबल क्लिक करिए तो आपको एक दिखेगा सर. फिर वो जो चीज आएगी उस पे क्लिक करिए ऑन द लेफ्ट साइड ऑफ योर स्क्रीन से. आपका पूरा डेस्कटॉप की तस्वीर आएगी सर.
Yeah.
अब आ गया सर. वेरी गुड.
But it's not visible to me now. It's not visible to me now.
Your screen is visible, sir. Now you can start your, you can click on your presentation.
Okay.
Yes. Sir. Yeah.
So
on presentation, slideshow mode. Yes.
Perfect, sir. Perfect.
Okay.
Thanks.
So first of all, I would like to thank Dr. Puneet Agrawal for in giving me opportunity to present this presentation. This is my topic is outcome of the surgical treatment of the hip fractures in elderly patients with multiple comorbidities. So the aging population is rapidly increasing here. We have a lot of patients, elderly patients, and those the age, it's definitely increasing. And the more problem is these all elderly patients, they have multiple comorbidities, and they also have high chances of hip fractures, mostly because they have high tendency to fall and their bones, they are osteoporotic. So this multiple comorbidities like diabetes, hypertension, cardiac diseases, liver diseases, Parkinsonism, these are also on increase in these elderly patients. And these patients, they have the hip fracture with the multiple comorbidities. So began in tertiary center, we started getting a lot of these patients with multiple comorbidities, which were referred to us from various sites. So we had a lot of question here that how does we manage these patients? The conservative treatment, FITIM definitely should not be any answer because we have seen a lot of patients, even not with the comorbidities, if we leave them conservative, they have a lot of problems of the morbid immobilization, bed sores, contractures, and all those things. But on the other hand, these morbidities, they make these patients even more crippling. So if we do the surgery, we have the fear and doubt, what will be the effect of anesthesia on these patients, elderly patients with multiple comorbidities? What will be the effect of these multiple comorbidities? How will there will be the post-operative physiological status? And the one big question is always, we always have a fear of mortality of these patients. So we just, because we are getting a lot of these type of the patients, so we searched some of the literature. like the influence of comorbidities on the functional outcome of the patient's surgically treated fragility fractures. They concluded that this study confirmed that the comorbidities, particularly dementia and diabetes, significantly influence the functional outcome 6 months after the fragility fracture, and surgery definitely improves the mobility. The other literature shows the comorbidities as a dominant predictor of the mortality after hip fracture surgeries. They concluded that 1-year mobility rate is not influenced by the comorbidities. According to Lorraine Backplace, the comorbidities delaying surgery worsens hip fracture outcome. The clinical effect of surgical delay in older patients with multiple comorbidities and hip fractures is controversial, but the conclusion is early optimization of comorbidities and surgical intervention prevents physiological status deterioration. While the determinants of functional outcome of the hip fractures, the role of comorbidities, the comorbidities determine the post-operative outcome in elderly patients. So after seeing all these summed of literatures, we did a retrospective analysis of 69 elderly patients of the hip fractures managed by us by the surgical intervention between January 2022 to December 2022. And out of these 69 elderly patients of the hip fracture, 15 patients had 2 or more than 2 associated comorbidities. These were all managed by the surgical intervention. In the retrospective analysis, these 15 patients were called for the follow-up, or they were just contacted by the phone to know about their rehabilitation status, activities of living, daily living, morbidity, and mortality. So we found that 2 patients, they expired within 3 months after the surgery, and 1 patient expired within 3 months after the surgery. But rest of the 12 patients, they were still surviving. They were able to do their activities of the daily living with or without support. And we collected their data. We just found that the patient's maximum age group of the patient was 82 years. He had ejection fraction even 54%. We operated him within 48 hours of this injury. He had 3 or 4 episodes of hospitalization related to the cardiac problems, but the patient was completely mobile. He was doing his all activities. 1 patient expired only after the, because there was some delay, patient presented delay, and we operated 10 days after that. So he expired after 3 months of the surgery. Similarly, there were other patients, most of them were able to perform their activities of living, but a few patients, there was a delay in the surgery, or there was, because of the other comorbidities, only 3 patients expired, but the 12 of the patients, they were able to do their all activities. So inspired by this, all our retrospective analysis, we started doing a prospective studies since January 2023 to find out the outcome of surgical treatment of hip fractures in elderly patients with multiple comorbidities. And in this study, we are being supported by 2 of the anesthetists, 1 physician and 1 statistician. Our aim is to assess the effect of preoperative multiple comorbidities in elderly patients with hip fractures on operative management, to analyze the association between comorbidities and outcome of surgical treatment in elderly patients with hip fractures, to evaluate the functional rehabilitation outcome of postoperative management in elderly patients with hip fracture with multiple comorbidities, and finally to predict the effect of operative treatment on morbidities and mortalities of elderly patients of hip fracture with multiple comorbidities. We use some other parameters, like we have taken elderly patients that is more than 65 years of the age. We had the evaluation and management of multiple comorbidities. We have included more than 2 or 3 comorbidities. We looked for the time interval between the injury and surgery and influence of delay in the surgery on outcome. parameters we used like American Society and Association score, Carson's comorbidity index, Possum's score, which have 4 components: physiological, operative, morbidity, and mortality scores. So since January 2023, 27 elderly patients of multiple comorbidities, they have been managed by the surgical intervention. And out of these 27 patients, we were able to do this analysis of 5 patients, and out of 5 patients, 1 expired within 3 months of the surgery. So this is what is the post-operative analysis. The 1 patient who expired within 3 months, he was bedridden even after the surgery. His scores were all alarming before the surgery. So we had used the ASA score, which has the 5 grades, 1 and 2, where the patient can be operated easily, but the grade 4 or 5 that shows the worsening. And our patient, he had the grade 4 of ASA score, who got expired. Similarly, the other patients who survived who had a score of 2 or 3. Similarly, Carson's comorbidity score. This is a tool which is it is basically uses 3 medical conditions, and these scores are given on the basis of these conditions. Higher this score corresponds to the more of the risk of the mortality. And these are the 19 criteria which comorbidities which are included in this scoring system. Again, if we see of our 5 patients, the patient who expired, he has about 10 of the score, which was the maximum. Similarly, we have the Possum's score, which has the components of the physiological, operative, and morbidity and morbidity scores. These scores, again, the higher is the physiological and the operative scores, higher is the risk factor for these surgeries. So here again, we can see that the patient who is expired has the more of the morbidity percentage and mortality. And he also has the physiological and operative scores, which are on the higher side. So we looked for all these patients, 5 patients. Out of 5, 1 expired, 1 is still bedridden. But the 3 of the patients, they are walking with support. 1 patient who was operated for the fracture neck femur is walking without support. All of them are able to do their activities of daily living. They are at least they are having their status, which was almost as pre-injury status. So though it's the it's a small study, with this study at present, we can conclude that the preoperative assessment of the patients with the hip fracture with multiple comorbidities and early surgical intervention can be predicted what is the operative outcome of these patients. It can also help in predicting the morbidity and mortality of these patients. And the topic that is the outcome of surgical treatment of hip fractures in elderly patients with multiple comorbidities is a research-oriented and interest in the present scenario, especially in India, as not much work is being done in India. And though this, we are in very early stage of this study, until now we have very less number of cases to give any final conclusion. We will also try our best to present our final outcome, at least after 1 year of this surgery, this study. And so what is the purpose? Just I want to present this topic only to get the opinion of my seniors and colleagues about this surgery, and as well as get the support and encouragement from all of you for conducting this study. Thanks you very much.
Thank you, sir. Any questions from the panelists and faculty members?
Sir, can I ask a question? Hello?
Yes.
Yes, sir. Yes,
Yes.
sir.
Yeah. Sir,
Stop sharing to the top.
Hello? Hello?
Hello.
Hello, am I audible?
Yes, sir. Yes, sir. Yes, Himanshu, sir. Proceed.
Yeah, sir. There are primarily two hip fractures: the fracture neck of femur and fracture intertrochanteric. So, were there any were they the patients were subgrouped into fracture neck of femur and fracture intertrochanteric also?
No, no, because we just want to know the one of the problem with the hip fracture, either it is a neck fracture or intertrochanteric fracture. If the problem will be of the immobility of the patients, so we want to provide them mobility. We want to provide them a trauma status for these patients. So we're not comparing the neck fracture or intertrochanteric fracture, because both of them have, if we treat them conservatively, both of them have the long immobilization, and that can affect on their comorbidities and finally morbidity and mortality status. Maybe if we extend our study later on, we can see what is the outcome of the neck femur or intertrochanteric fracture. But at present, to increase the number of cases, we are including both type of fractures.
Okay. Thank you, sir. Thank you.
Okay, welcome.
There is one question from the audience. Dr. Gaurav Sanjay is asking about how often do you use DVT profile axis for your elderly hip fracture patient, and what is your treatment protocol for DVT profile axis?
As far as my personal experience, I operate these patients and start mobilizing them as early as possible. So I am not using any DVT profile until unless there is some suspicion or there is some possibility of that. Because the hip, if neck fracture, if I operate them replacement, next day I start mobilizing them, and same is with the IT fractures. At least sitting quadricep exercises, non-weight bearing exercises, non-weight bearing walking, I can allow them.
Okay. So I think there is no questions, and so should I conclude here, sir? Dr. Puneet, sir?
Sure.
Yeah.
Okay, sir. So thank you all our office bearer of Indian Orthopaedic Association to join our starting webinar of Uttarakhand Orthopaedic Association. Thank you, Dr. Ram sir. Thank you, Dr. Naveen sir. Thank you, Dr. Atul sir, who is not with us today, but Dr. Anup sir and Dr. Puneet Gupta sir. Thank you, our panelist, Dr. Himanshu sir, Dr. Ganesh, Dr. Pradeep, Dr. Tarun. Thank you, Ortho TV. Thank you, Ashok Sham sir. Thank you, Rishi. Thanks to our viewers.
Thank you, Puneet.
Once again, thanks, Dr. Puneet
Thank you.
Agrawal, for giving opportunity to present my work. I think this is one of the procedure which I'm trying to do in Uttarakhand here, because we get a lot of these type of the patients. What is the final outcome? I think I will be able to answer it after completion of this study.
Definitely, sir.
Yeah, definitely.
Okay. Good night, sir.
Okay. Thank you, sir.
Good
Good
night.
night. Good night.
Okay. Thank you, Ashok sir.